So good afternoon. Um, so we'll be discussing delayed puberty under the following headings. I will be briefly touching upon the management and treatment options because it is a very vast topic in itself. So delayed puberty, it is defined as the absence of clinical signs of activation of hypothalamo-pituitary gonadal axis by an age that is greater than 2 to 2.5 standard deviation from the mean of general population. So in boys, if there is lack of testicular development by 14 years of age, and girls, if there is absence of breast development by 13 years of age, it is defined as delayed puberty. Normally, the pubic hair development is not included in the definition because we say that pubic hair development is mainly dependent on the adrenal component, and adrenarche and gonadarche might not occur simultaneously in a child. So it is excluded. Sometimes in some children, they start puberty at normal age of pubertal onset, but there is slow pubertal progression or there is stalled puberty. This is also included sometimes in under the definition of delayed puberty. So what are the causes of delayed puberty? Primarily, depending on the gonadotropin levels at the usual time of puberty, we have the causes are divided into two: the hypogonadotropic hypogonadism and the hypergonadotropic hypogonadism. The most common cause being the constitutional delay in growth in puberty. The second one is the functional hypogonadotropic hypogonadism, permanent, and the least common, that is 5% of males have hypogonadotropic hypogonadism. So what is CDGP? CDGP is actually a physiological prolongation of the normal physiological hypogonadotropic state in a child. After mini puberty till the age of puberty, normally the children have physiological state of hypogonadotropins. And if it is prolonged, so it is said that it is the physiological extreme of the extreme age of pubertal onset. Normally, in around 80 to 90% of children, we see associated slowing of growth. That is the reason why it is called as CD, growth, constitutional delay in growth in puberty. But if there is only pubertal involvement, there is no growth affection, then it is called as self-limited delayed puberty. We get around, in 50 to 75% of cases, we get family history of delayed puberty in one or both parents. But the thing here is to understand that even the congenital hypogonadotropic hypogonadism has a significant family history, where if you are getting one or both parents having history of delayed puberty, a suspicion of CHS should be kept as well. And because it said that even the CDGP is thought to have an AD inheritance, and they have genetic variations. It has been found in Brazilian CDGP cohort that children had heterogeneous missense variants in several genes of CHH, in which IGSF10 and GHSR were the most prevalent affected genes. The second one, the functional hypogonadotropic hypogonadism, it is the second most common cause of delayed puberty in males. So in this condition, there occurs suppression of the normal HPG axis because of any chronic systemic illness, any endocrinopathy, because of any medications, or eating disorders, malnutrition, or even excessive exercise independent of the body weight changes. But it has a significant inter-individual variability. Not every child affected with a particular systemic disease will have hypogonadism. The third one is the permanent hypogonadotropic hypogonadism. It can be congenital or acquired. It can be complete or partial. When we are saying partial, when the child starts at the normal, starts the puberty at the normal age of puberty onset, but either there is poor progression of puberty or the puberty gets arrested. The congenital HH can be associated with anosmia or hyposmia, where it is called as Coleman syndrome, and it can be associated with normosmia. There can be multiple pituitary hormone involvement or only the gonadotropin affection. There can be various associated genetic syndromes where isolated or multiple pituitary hormone affection is seen. And in acquired causes, usually we get history of head trauma, irradiation, chemotherapy, or CNS features like of raised ICT or headache. So, as we know that the GnRH neuron, they develop in the nasal placard and then they traverse to the median eminence. So the genes which are involved in the GnRH neuron neurogenesis, GnRH neuron migration, survival, axon elongation, and signaling and secretion, these all are the causes of CHH. Around 50 to 60 genes have been till now discovered to be the causative genes for CHH. And the last cause, that is the hypogonadotropic cause. We have to understand that though we are saying hypogonadotropic hypogonadism, if we are evaluating a child in the prepubertal state, we might get the gonadotropin levels absolutely normal or absolutely in a hypogonadotropic range. So this hypergonadotropic we have to read in context of the actual age of puberty. In this case, primary gonadal failure occurs. There can be congenital causes or acquired causes. So, how to differentiate between these causes of delayed puberty? So, usually we start with history and physical examination. Normally, in CDGP, we get significant family history of delayed puberty, but as I told you that CHH can also have significant family history of delayed puberty. The CDGP children, we can get decreased growth velocity, particularly between ages of 2 to 5 years. But any child suffering from any chronic systemic illness can have delayed, decreased growth velocity as well. In permanent hypogonadotropic hypogonadism, we might have some history of CNS trauma, irradiation, or CNS pathology. The history more specific for PHH might be absent or decreased sense of smell, history of cryptorchidism, history of renal agenesis, deafness, syndactyly, skeletal anomalies, cleft lip, cleft palate. But it is said that even in some causes of hypogonadotropic hypogonadism, you can get the history of cryptorchidism as well as micropenis. In physical examination, usually in PHH, we get testicular volume of less than equals to 1 ml, bimanual synkinesia, and adenarche, and usually the adenarche is found at normal age in PHH and hypogonadotropic hypogonadism. In CDGP, there can be delayed adenarche as well as puberty. So, how to proceed? If we have taken a good history and examination, then we have to do basal LH and FSH along with early morning testosterone levels. If the basal LH and FSH are high, it tells us that we are dealing with hypogonadotropic hypogonadism. And then the further testing to see what is the cause of hypogonadotropic hypogonadism has to follow. But if our history and physical examination is guiding us to any chronic disease, then targeted investigations has to be done to see which type of chronic disease the patient has, for which LFT, KFT, celiac screen. The anterior pituitary hormone testing will be needed for CHH as well as some causes of FHH like hypothyroidism. Other hormonal testing like looking for hypercortisolism, hyperprolactinemia need to be done. Bone age might not help us in differentiating between these entities. USG KUB to look for renal agenesis. and olfactory testing. And if any positive investigation is there, we can go ahead with MRI brain, otherwise as well. But it is said that when you have some positive pointers on history examination or your investigations for CHH, the MRI brain is diagnosis in around 30 to 40% of cases. If we don't get anything positive in till now, then we can go ahead with the genetic panel, and even the genetic panel has a yield of around 50%. So after all these investigations, there might still be confusion whether we are dealing with CDGP or CHH. Before going forward about the dilemma about CDGP and CHH, I want to talk regarding the Sertoli cell peptides. As we know that the testes in the neonatal age group is mainly formed by, the testicular volume is mainly formed by the Sertoli cell component. And in the mini puberty, when there is FSH exposure, the Sertoli cell they proliferate and the number increases, and it is required for the good health of Sertoli cells. With the proliferation, there occurs increased concentration of AMH. In puberty, with the increased FSH levels, there occurs androgen receptor expression in Sertoli cells, and with increased intratubular testosterone levels, there will be negative feedback mechanism of AMH, and the AMH levels will start decreasing, but the inhibin B levels will increase. So normally we see high gonadotropin levels at 3 phases of life: in second to third trimester, during mini puberty, which usually lasts from second month to 6 month or 2 weeks onwards in male child, and in the phase of puberty. So as you can see that the AMH level will decrease after the onset of puberty. The inhibin level will be there, detectable inhibin level will be present, and it will increase with the onset of puberty. And it is said that sometimes these Sertoli cell peptides can be used to differentiate between CHH and CDGP, as we see that as the CHH children will not have the phase of mini puberty, there will not be increase in inhibin and AMH levels. And with the low gonadotropins, low testosterone, we will see low levels of AMH and inhibin B in these children. But because there is a significant overlap we'll see how this test have fared in actual real life situations. So to differentiate between CDGP and CHH, the best thing is either we can wait and watch till 18 years to see whether there is onset of puberty. But after 18 years, we have to wait for next 3 to 4 years more to see whether the puberty is progressing or not, to call it complete or partial. Or we can give low-dose sex steroid priming in the form of 50 to 100 mg of testosterone esters monthly for 3 to 6 months. The other testosterone preparations like testo-gel and transdermal patches can also be used. And then we have to see after the priming, after 3 to 4 months, to see whether the testicular volume is increasing or not. But wait and watch is not feasible because delayed puberty has a significant psychosocial implication, and the body composition and bone density also suffers. So many researchers have used basal gonadotropin levels and basal testosterone levels. Also, these levels after stimulation by with the GnRH agonist or HCG to see whether that is helping them to distinguish between the two entities. But many tests have been done, and there is no gold standard test to say that these are the cutoffs which can distinguish between the two. So now the focus have shifted to the Sertoli cell peptides basal as well as GnRH agonist or FSH stimulated inhibin B and AMH to see whether that can help. But that can help. So in this study, as you can see that the researchers have used the basal levels as well as the stimulated levels, and they have used a combination of tests to see if there is a good sensitivity and specificity of a particular test. They have found a good sensitivity and specificity of 183% of basal LH, of basal inhibin, similar sensitivity and specificity, and 3-year post leuprolide LH as 195%. And when they combined basal inhibin B with basal LH, they found a sensitivity and specificity with negative and positive predictive value of 100%. Researchers have used have taken the use of testosterone priming as well to see whether the cutoffs have better differentiation capabilities. But where after the testo priming for 3 months, they have seen whether the triptorelin stimulated LH of more than 14.7 or basal inhibin B levels of more than 94.7 can help in distinguishing between CDGP and IHH. The FSH stimulated inhibin B has also been seen to have a very good 100% sensitivity and specificity. But all these studies are marred by the fact that they have a very small number of children suffering from IHH. So how much this cutoffs will actually help in differentiating is not clear.
Dr. Pragya, we need to wind down.
Yeah. So the treatment will, so regarding treatment, we want we want the endogenous puberty to set in or to develop secondary sexual characteristics in male by any method so that the child can have age appropriate body composition, bone density or psychosocial development, to have good fertility prospects. So there are two approaches to treatment, either by testosterone or gonadotropins. But it is said that the testosterone can lead to SPL enlargement, development of facial and body hairs, composition, deepening of voice, but it will not change the testicular volume and does not promote spermatogenesis. And also testosterone levels after IM injection might not be consistent throughout. So though testosterone is the main treatment for primary hypogonadism, where we are not seeking fertility, where we know that the fertility prospects are very low. So now the interest is shifting towards gonadotropins because they can help in testicular maturation, can help in endogenous testosterone secretion, stimulate spermatogenesis, and can have psychological benefit for the patient. There are many regimens which are available, which is used, but it's said that if the testicular volume is low, it's always better to give a good amount of FSH, initial treatment of FSH, so that there is better Sertoli cell and testicular growth, and then only the sequential treatment with SCG or GnRH can follow. But not all patients respond very beautifully to this treatment. It's said that if a patient has cryptorchidism, positive genetic background, and complete form of CHS, they have poor response. And the body proportions were significantly related to the age at the beginning of the puberty induction, duration of growth during induction, initial bone age, and the duration of growth during induction was associated with previous testosterone priming. The last slide is about, as we were discussing the window of mini puberty as well. So researchers have used this window to see if treating other than by testosterone will help, give better, will help the child better. So it's seen that the gonadotropins, treating by gonadotropins might help them in increasing the testicular volume, the penile length, as well as in testicular descent in some of the cryptorchid children. But because most of the studies are done after 2015, we are yet to have the actual data in the adult life, whether it is actually helping the males in pubertal age group. So to summarize, delayed puberty is defined as the absence of testicular development in boys by 14 years of age. Majority start puberty with appropriate treatment of underlying systemic illness or watchful waiting. CDGP is the most common cause, but it is a diagnosis of exclusion. The congenital hypogonadotropic hypogonadism is characterized can be in partial or complete and should be considered in the setting of low gonadotropins and sex steroid concentrations. Even with the advances in genetics and new biochemical approaches, differentiating CDGP from CHH is challenging. And the choice of HH, the hypogonadism treatment, you should be decided depending on the therapeutic goal, the timing of treatment, and the personal preference of each patient.